jump directly to the next one. Okay, so we can invite Professor Boccardi to join us.
So
hello, everybody.
I would like
Oh, sorry.
just to say panelists, Professor Boccardi, Professor Sikora, Professor Ivo Petrov, Professor Peschillo, and Dr. Alioski.
Yeah, I think I'm the only one left here, so me and Ivo. First of all, I want to thank the organization for allowing me to be here in this beautiful city. So this is a complication, and I think this is a very important part of what we do to try to speak about complication and share complication, because that's the only way we really learn. This is an old complication. I'm retired, so I have no more conflicts of interest, and my complication go back at least 40 years, so I took one a few years ago. This is a 40-year-old lady with several ischemic strokes in right hemisphere, so she comes with stroke after stroke, and she's with a left hemiparesis, and a CT shows holes in the right hemisphere, and you can see here the CT of this poor lady with multiple ischemic stroke. And angiography is this. So this is the lateral view. This is the AP view. It's obvious that you have a problem in the middle cerebral artery. If you do more accurate images, you see a very big and long stenosis of the middle cerebral artery, which of course is chronic because she's had this problem for a long time. So what should we do here? Anybody would think of treating this lady endovascularly? Yeah. So we decided to go, because she had repeating cortical and subcortical strokes, and so there is an indication for treatment. Of course, you could go for bypass surgery, but we decided at that time to do a PTA, just a PTA, and if the PTA doesn't work, go with a stent. And so we used a balloon, which was at the time Gateway, and a transient guide wire. Here you can see the wire in a branch of the middle cerebral artery. Yeah. And we did angioplasty here with a Gateway balloon. So there is just a little bit of opening of the vessel, so we were not bad. Let's see what happens. As usual with angioplasty, you stay there and look, and in effect, after a few minutes, the artery is almost completely occluded. This is something that we knew it could happen, and that's the reason why I think 15 years ago we would stent the lesion. And so we used the stent that was available at the time, the wingspan stent. I think nobody uses that anymore, and for a reason. And so here you can see the stent while we are deploying it. And again, not too bad. We have reopened the middle cerebral artery. Of course, it's not a big opening, but you don't need usually to have a perfect image. You just need to have flow. Oops. Yeah. So yeah, perfect. We remove the wire, and as you can see there, we have a hemorrhage where the tip of the wire was. So what we did was exactly this, that the wire moved during our procedure, and it went more distally into a perforator, and it ruptured the perforator, which is something that at that time we had seen already a few times, and since then we have seen it a lot of times. So the rupture of a vessel with a wire which moves around is something that you should really be aware and always control the tip of your wire, because that's when it happens. So you can see that it moved forward. So now we have a bleeding. She's under dual antiplatelets. It's not the first and not the last time we had this complication. So what should we do now? One of the possible things to do is to try to go there and occlude the point of rupture, at least temporarily with a balloon or coils, do something to stop the bleeding. We tried to go there, but we could not pass the stent anymore. So we tried with a microcatheter. At the same time, the flow diminishes. The PTA balloon doesn't pass so we cannot pass the wingspan stent anymore, and the flow diminishes, and terrible situation. So the middle cerebral artery is almost occluded. So now we have a bleeding, we have a stenosis which becomes an occlusion. We are very proud of what we are doing here. And at the end, there is a complete occlusion of the middle cerebral artery. So I did the best I could, as obviously, and I decided to stop because I cannot do anything anymore and hope in collaterals. At the time, we did not have the CT, cone beam CT in the angio room, so we just had to go. But you can see where the stent was. Can you see it? Yes, more or less. And this is the middle cerebral artery occlusion. There are some collaterals coming down from the anterior cerebral artery, and you have a better visibility of the anterior cerebral artery injecting the other side, and in fact there are some collaterals. So I hope in collaterals, also because there's nothing else I can do. CT scan shows the hemorrhage, which is not so terrible. There's some blood, but we don't have a big hematoma. So we just wait. After a few hours, still not a big hematoma. 24 hours, oh, beautiful. This is a perfect image that I would have seen. So the complete occlusion of the top of the middle cerebral, of the internal carotid artery. So worse than this, it could not be possible. But still, the other side shows somewhat good collaterals. I will show them again so you can see them. So the clinically she's stable. Luckily, she has slight worsening of her left hemisyndrome, improving in the following days. So it's even improving. So it's an old complication. What would we do differently today? Probably we would go immediate for stenting, probably with a coronary balloon and not with a wingspan. Of course, most important thing is to watch where the tip of the wire is going while you work. This can happen anything you do in the brain, and probably use a modern guide wire, not the transend. We do a control after 1 month. Not so terrible. It's almost exactly the same as before. You can see that the stent is still there, and there is no middle cerebral artery, so it's still occluded. The stent is occluded, no more middle cerebral artery. And how is she from the point of view of the neurological status? Well, she's back to the situation before treatment, luckily, and most importantly, she has no more strokes. So it's much better to be lucky than good. Thank you very much.
Questions from the audience.
Go ahead. It's extremely deductive case. It's really what we are fearing about is that in fact happened. And we have to have on our armamentarium different bailout techniques. It's definitely very important. And I would like to ask you, you are the expert in this field, what would be your behavior in such a situation nowadays?
I have a personal question to Professor Boccardi. After working all these years with Marco Centrato, would you consider an STA-MCA bypass to this patient if you go back?
Yeah. Of course, that's one possibility. The other possibility would have been to give better antiplatelet treatment, medical treatment, and just wait, not to have strokes. Why did she have strokes? Because she was just embolizing from that stenosis. So maybe just having a better medical treatment could have been enough, and a bypass surgery could also be a good option. Yes.
Don't you consider that it would be possible to put the wire in another branch? I think there is a bigger branch aside, just parallel to this one, the target one. And I can guess in case the wire was in the other branch, it wouldn't happen. So probably slight different projection can discriminate between the branches and the target branch.
Yeah, you're right. But on the other side, it's not because it's small or big, because the hemorrhage comes usually when the tip of the wire enters a perforator. So from that point of when you pass from M2 to M3 is exactly where all the perforators go from the sylvian fissure to the inner brain. And so if the tip of the wire gets into the perforator, especially that wire, which was a terrible wire, can break and rupture this very small vessel. So it's not really the size of the larger vessel, but it's the fact that you shouldn't go too far into where you shouldn't go. Yeah, but I agree. You could, of course, I cannot say that if we went to the other branch, it would not have happened. Yeah, I cannot say that.
Thank you. Very brave to present such a case. So why put it all the way there? Why don't just leave it in the proximal M2?
No, it was a mistake. We wanted it where it was, but you pull while you bring up the stand, and by doing that, you control your device which you are pulling, and you don't control the tip of the wire which is up there. So you're looking here, and something is happening up there. That's what happens in many things we do. So it would be better to have 4 eyes, somebody besides you that looks at the tip of the wire and says, "Hey,
Matthias,
you're going too far." Six eyes.
Klaus, could you join us? Please join us. So you have fantastic presentations about complications. What is your comment in this regard, in this case?
Yes, I think it was everything already mentioned. Yes.
Yeah.
First, avoid it, not to have this complication. Yes, that's the first thing. Because don't forget, cerebral arteries are only 2/3 in the thickness, the vessel wall, in comparison to other body arteries. So it's very easy to perforate. And the other point is, yes, already mentioned, yes, control your guide wire. Yes, it should not happen.
Yeah, and probably with the new guide wires, it's more difficult that it happens because you control them better. That was very stiff and typical. And with the tip, it was a platinum coiling tip, which is something that we don't have anymore. So we had a few cases of rupturing with that guide wire, and we don't like it, and we stopped using it. Maybe.
Thank you.
And it was a very tiny branch because, as
Yeah.
you see, when you injected contrast material, the branch was not filled
Yeah.
by contrast material, only the other branches.
Yeah.
Okay, we
Thank
can
you.
go further.
Yeah.